new lumbar arthroplasty device we received FDA approval in almost the last decade, and it is also received a superiority claim from the FDA, and it is also the first posterior lumbar arthroplasty device to receive approval. So Vince, educate us, buddy.
Great, thanks, and thanks to ISASS for having me here. So yeah, I'll be talking on posterior facet replacement. I have no relevant disclosures, but our group was one of the FDA IDE sites for this device. So I'll start with this patient I saw earlier this week in clinic. This is a 60-year-old male, comes in with a grade 1 L4-5 spondy, back pain equal to leg pain, ODI of 24, VAS back of 9, VAS leg of 9, failed all the non-surgical care. And I thought this was kind of the perfect case to kind of illustrate the conversations we've had today around how to treat these patients with motion preserving options. Here's this flexion extension x-ray with a millimeter or so of movement. And so if we put this case up, and we could probably have an hour-long debate over how to treat this. So decompression alone, we know the studies supporting that. We know the studies supporting decompression and fusion. And the fact that there's not consensus on between those two makes us wonder if maybe there's another option that we haven't explored yet. And that's really where posterior facet replacement or posterior decompression, dynamic stabilization with the facet replacement system like TOPS comes into place. So the goal of motion preservation, as we've heard from the previous talks, is to address the pathology while maximizing preservation of function. And that leads to index level motion preservation, which reduces adjacent level stresses and really leads to reduced adjacent segment diseases. Some of those longer term studies have demonstrated that were shown previously. The problem is the only arrow in our quiver for the last 2 decades has really been the lumbar disc replacement, but it's a fantastic option as Rick was just speaking about, but the problem is that's just a small segment of the population. These are the lumbar fusion cases over from 2004 to 2015 in the US, and the primary indications for them. Disc degeneration is a small slice of that. But there's never any option for motion preservation for this large portion, greater than 50% of the patients that were getting fusion for spondylolisthesis or stenosis. And that was until recently the FDA approved the TOPS device, which is a posterior facet replacement device that allows for decompression posteriorly for spondylolisthesis and stenosis with dynamic stabilization. So the device itself is a pedicle screw-based device intended to replace the facets and posterior elements following aggressive decompression. Essentially, it's a posterior column osteotomy with complete decompression. And it's a titanium construct with a PCU core. It's placed with a posterior approach, decompression, screw, traditional pedicle screw placement, and then the device goes into polyaxial pedicle screws. This allows for physiologic movement, and it was studied in 2017 with the IDE trial, which concluded and now is FDA approved as of 2023 and now commercially available on market. Here's a quick video. This is again another case in L4-5 grade 1 spondy with severe stenosis. Flexion extension x-rays, and this is intraoperative video, so it's placed through midline traditional open exposure after complete decompression. Dom taught me how to do this at this speed, so after pedicle screw placement, the device is in trial and insert, but while you're placing the pedicle screws, it's very important to do this technically very precise here. There's going to be a lot of stress on these pedicle screws because there's going to be maintained motion through the device, and so you don't want to be doing multiple passes and multiple tries with your tap and with your gear shift. You want to make sure on the lateral x-ray that the pedicle screws are lined up well so the device is accommodated well. After you place the pedicles, you place the pedicle screws, you place the trowel, and that allows you to make sure that the appropriate size implant is selected. It also allows you to adjust the height of the tulip heads to properly accommodate the implant. This is probably the most nuanced part of this for someone that hasn't done it before. Just kind of getting used to the trial and making the adjustments and placing the screws in a manner that make it easy for the implant to go in. The implant itself is fixed. There's no mobility to it, so you really need to do the pedicle screw work in order to make sure that it is implanted smoothly. And then once the pedicle screws are replaced, you decide the size of the implant, and you prepare it on the back table, injecting the core with saline. The implant's then inserted, as you can kind of visualize here, and the set screws are placed and final tightened just like you would for any other rod insertion. final view of the implant. So the indications for TOPS or posterior facet replacement really go off of the IDE criteria. And that's really single level grade 1 spine with or without stenosis, L2 to L5. Some of the main excluded criteria are scoliosis, BMI greater than 40, osteoporosis, multi-level, and then less than 4 millimeters of disc height in order to be able to accommodate the implant. So there's now level 1 data on this from the IDE trial. So this is the prospective multi-center randomized controlled trial of TOPS versus TLIF. It was intended to be 500 patients, but stopped early due to the interim analysis showing TOPS being superior to TLIF. So this is the VAS back and VAS leg outcomes of the percentage of patients achieving greater than 20% improvement. And you can see that the results are similar as you would expect, right? The effect of the outcome is really the decompression, which is very, very similar amongst the groups. Then looking at the overall composite clinical success, which was a scale basically using these 4 criteria of no supplemental surgical intervention, no device breakage, ODI improvement, and no neurological deficit. Having met all 4 of those, TOPS was superior at 85% versus 63% in the fusion group. And that led the FDA to make the statement in their safety and effectiveness data report saying that the TOPS system is superior to the controlled treatment fusion, right? This is not just saying that it's not inferior as we saw with a lot of the ACDF versus arthroplasty data presented earlier. This is a superiority at 2 years. Then looking at range of motion, right, as Roland had said in the original talk, does it really preserve motion? This is the preoperative motion of the patients as well as the 2-year motion, flexion, extension, and lateral bending, and you see it really matches the preoperative physiologic parameters. And then finally, the surgical re-interventions. What are the complications from a new device? The reoperation rates were low in both groups, and reoperation rates for device-related failures was very low in the TOPS group with only 1 implant migration boost required revision. So in summary, TOPS is the only FDA-approved posterior arthroplasty device which now allows us to treat those pathologies that were traditionally treated posteriorly with either decompression and fusion or decompression alone with a decompression and dynamic stabilization motion preservation option. Superiority versus TLIF in the IDE trial is demonstrated at the 2-year mark. There's longer-term follow-up needed for this device, although it's been implanted outside the U.S. since 2012, and there's some long-term case series showing good outcomes with that. But we also need to, in the future, with the iterations, need to continue to incorporate MIS principles into posterior approach to arthroplasty. This is a picture I have, or someone sent me of a TOPS case where you can see staples up and down the spine and big midline open incision. So as we iterate more of these in the future, we need to find minimally invasive ways to implant motion preserving technologies. And I think motion preservation in the future will require a 360-degree approach, much like we approach lumbar fusion currently.